Fetal contraction stress test. The physician evaluates fetal response to induced contractions in the mother. The physician applies external fetal monitors to the maternal abdominal wall. Pitocin is given intravenously to the mother to cause uterine contractions. The fetal heart rate and uterine contractions are monitored and recorded for 20 minutes to determine the effect of contractions on the fetus. This procedure is usually performed during the third trimester. Amniocentesis, diagnostic. The physician aspirates fluid from the amniotic sac for diagnostic purposes. Using ultrasonic guidance, the physician inserts an amniocentesis needle through the abdominal wall into the interior of the pregnant uterus and directly into the amniotic sac to collect amniotic fluid. Amniocentesis, therapeutic amniotic fluid reduction, includes ultrasound guidance. The physician performs a therapeutic amniotic fluid reduction. Using ultrasonic guidance, the physician inserts an 18 or 20 gauge amniocentesis needle through the abdominal wall into the interior of the pregnant uterus and directly into the amniotic sac to remove excess levels of amniotic fluid, amnioreduction. Chordocentesis, intrauterine, any method. The physician removes blood from the fetal umbilical cord for diagnostic purposes. Using ultrasonic guidance, the physician inserts an amniocentesis needle through the abdominal wall into the cavity of the pregnant uterus and into the umbilical vessels to obtain fetal blood. Fetal non-stress test. The physician evaluates fetal heart rate response to its own activity. The patient reports fetal movements as an external monitor records fetal heart rate changes. The procedure is non-invasive and takes 20 to 40 minutes to perform. If the fetus is not active, an acoustic device may be used to stimulate activity. Transabdominal amnioinfusion, including ultrasound guidance. The physician infuses an abnormally underhydrated amniotic sac with fluid. This may be done as a prophylactic measure for the fetus or to enhance sonographic imaging. An amniocentesis needle is placed through the mother's abdomen and advanced between extremities of the fetus under separately reportable ultrasound guidance. Normal sterile saline is infused into the uterus until the fetal anatomy is adequately visualized. The needle is removed and a detailed ultrasound is carried out. Transabdominal amnioinfusion procedures may also be conducted prior to invasive procedures, e.g., fetoscopy and fetal shunts, to allow placement of instruments. Fetal umbilical cord occlusion, including ultrasound guidance. Fetal umbilical cord occlusion is carried out in cases of complicated monochorionic multiple gestation pregnancies or in cases to terminate a pregnancy due to a birth defect. Ultrasound is used to locate access to the umbilical cord, avoiding the placenta. Using ultrasound guidance, small forceps are advanced into the uterus and the cord of the affected fetus is identified and grasped. The umbilical cord may be ligated, occluded, or compressed. Complete absence of flow through the cord is confirmed and the instruments are removed. Fetal fluid drainage, e.g., vesicocentesis, thoracocentesis, paracentesis, including ultrasound guidance. Fetal fluid drainage is done in cases of pleural effusions or pulmonary cysts, and especially in fetal megavesica, a rare syndrome caused by functional obstruction of the fetal urethra. The fetus bladder is enlarged. Oligohydramnios, dilation of the lower and upper urinary tract, and hydronephrosis may also be present. Pulmonary hypoplasia can result from this and lead to hypoplastic abdominal musculature, urinary tract anomalies, and cryptorchidism. The fetal urinary bladder is emptied by transabdominal intrauterine vesicocentesis. Under continual ultrasound guidance, a 20 to 22 gauge needle is inserted through the mother's abdomen and advanced into the fetus bladder. Fetal urine is aspirated and sent to the lab for analysis of urinary electrolytes and to determine renal function. The needle is removed and the patient kept for monitoring for up to another hour to check for refilling in the bladder. Fetal shunt placement, including ultrasound guidance. Fetal shunt placement is performed for pleural or vesical amniotic shunting in cases of pleural effusion, pulmonary cysts, or fetal megavesica, where the bladder is enlarged because of urethra blockage. Shunting is done to supply continuous drainage when reaccumulation of fluid is not successfully treated by isolated vesicocentesis or thoracentesis. Fluids can be drained into the amniotic cavity through a double pigtailed catheter. The entry site on the mother's abdomen is cleaned with antiseptic solution and local anesthetic is infiltrated down to the myometrium. Under ultrasound guidance, a metal cannula with a trocar is introduced transabdominally into the amniotic cavity and inserted through the fetal chest wall in the mid-thoracic region, into the effusion or cyst. The trocar is removed and the catheter is inserted into the cannula. A short introducer rod is used to place the proximal half of the catheter into the effusion or cyst. The cannula is gradually removed into the amniotic cavity where the other half of the catheter is pushed by a longer introducer. There is now a conduit for fluid drainage into the amniotic space. Placement of the shunt is confirmed, the instruments are removed, and the patient is monitored for 1 to 2 hours. Follow-up ultrasound scans are performed at weekly intervals to check drainage and determine if the effusions reaccumulate, in which case another shunt may be inserted. The drains are immediately clamped and removed after delivery. Fetal scalp blood sampling. The physician samples fetal scalp blood during active labor for diagnostic purposes. This test, which assesses fetal distress during labor, must be done when the cervix is dilated more than 2 cm and the fetal vertex is low in the pelvis. The physician breaks the amniotic sac in patients whose water has not broken spontaneously and inserts an amnioscope through the vagina. An incision is made in the scalp with a narrow blade that penetrates no more than 2 mm. Blood is aspirated into a tube. Fetal monitoring during labor by consulting physician, i.e., non-attending physician, with written report, supervision and interpretation. A consultant other than the attending physician attaches an electrode directly to the presenting fetus scalp via the cervix. The electrocardiographic impulses are transmitted to a cardiotachometer which converts the fetal electrocardiographic pattern into recorded electronic impulses. A catheter is inserted through the dilated cervix into the amniotic sac to measure and record the intervals between contractions. The procedure is supervised during labor until delivery. The recordings are analyzed and accompanied by an interpretive written report. In 59051, the consultant initiates the monitoring, provides the analysis and interpretive report, but does not supervise the patient during labor.